I welcome on the dais Dr. P Singh, Principal Director and HOD, Critical Care, Max Super Specialty Hospital, New Delhi. So, sir, my first question to you is on the role of polymyxins in sepsis. So, in the era of multi-drug resistant infections, what is the current role of polymyxins in the management of sepsis? And are they sufficient as standalone therapy or do they require adjunctive treatment?
Yeah, that's an important question. Now, first, I think we need to discuss the total, a journey. In 2010, we had one paper published where we mentioned the NDM, New Delhi Metallo-Beta Lactamase producers. There was a good amount of the storm brewed politically as well as in the medical community. And that time, the people came to know that these are the subset of the bacteria which is not being treated with the routine line of antibiotics. And then carbapenemase producers came into the picture. So in 2010 to 2013, we had a more of a ESBL producer, less of a carbapenemase, and from 2013 onward, we are having a more of a carbapenemase producers. And hence, our therapy also changed, and the polymyxin group of antimicrobials came into the picture. And because initially it was a good number of evidences was available that was going in favor of the polymyxin along with the carbapenem, predominantly the meropenem. So we use this combination successfully with good number of the patients with a good result, and following all the antibiotic policies, antimicrobial stewardship, which is a part of the organization where I'm working with. Now coming to this, where the polymyxin, definitely polymyxin working till 2 or 3 years back when we had your latest 2023 IDSA guideline where they start giving us some other direction to some other direction, then polymyxins are still having their important role in the management of the sepsis, but definitely now we are going as per your evidences molecular pattern of the antimicrobial resistance, we have changed to the other combinations. Now coming to your second part of your question, that whether the polymyxin to be used as a lone monotherapy or as a combination, monotherapy is not being recommended because it basically adds into your more of a adverse outcome, development of the resistance, so it should always be used in the combination. That is the preference.
Okay. Sir, regarding choosing the right therapy, given the availability of newer antimicrobials, what should polymyxins be preferred over, when should polymyxins be preferred over other last line agents for sepsis caused by MDR gram-negative pathogens?
Yes, in 2023 IDSA guideline, they says that if you are using the polymyxins for those infection for OXA 48, KPC, and they said that the combination which you are using for last almost a decade, more than a decade, they says that mortality is very high with that. So kindly go with the combination, newer combination of ceftazidime vector with the aztreonam. But now the problem comes only when you are dealing with the E. coli, the new villain, the same new villain, which is having some different kind of the resistance. And we call it a penicillin binding protein 3 site, where it is creating a problem. So this routine combination of aztreonam along with the ceftazidime avibactam is not working with that. In that situation, the polymyxin along with the other combination come into the picture for the treatment of these patients, depending on the site of the infection.
Okay, okay, sir. So, sir, regarding a very interesting aspect about combination therapy versus monotherapy, does combination therapy with polymyxins improve outcomes in septic patients, or does it primarily serve to reduce the risk of resistance? And which combinations are most effective?
The answer of both the subset of your questions are the yes. The combination therapies definitely helps in the better outcome, as well as it also helps in reducing your preventing, not preventing, it helps in the prevention of the antimicrobial resistance. Now, coming to the combination, nowadays we are using the polymyxins other than, as I mentioned, that it do not excreted by the kidney. So it should not be used for the urosepsis patient, other than those patients which is having a coming with the lung side of the lung involvement, blood, and the other sites where you can use the polymyxin along with the different combination. And different combination, which I am saying that we are using them with your phosphomycin, we using them with the combination of it was previously that this medicine was the low-risk medicine, still we are using because sensitivity pattern are coming with the from the microbiology, and it is being said that if you are having the two sensitive drugs are better than the one if you are dealing with the MDR bug.
Okay. So regarding toxicity versus benefit, risk versus benefit ratio, how can clinicians balance the nephrotoxicity and neurotoxicity risks of polymyxins against their potential life-saving benefits in septic patients?
Sepsis is the one thing which is associated with the high mortality rate. It is the bacteria which don't give you a time. And nephrotoxicity, neurotoxicity is not going to kill the patient immediately. It is the infection which is going to kill a patient. So my main focus is to kill that bacteria to contain the sepsis. Once I control the sepsis, it means my patient is this my side of the fence. Then I can look into that part. Kidney will give you enough of the time. Neuro complication, which are basically moment you will stop the medicine, they are reversible. They are not a permanent kind of a thing. So as far as these risks are concerned, the risk of the sepsis, the death of the due to the sepsis outweighing all these complications associated with the antibiotics. So it's primarily one has to focus to counter or kill that infection to save the life of the patient.
Sir, what emerging innovations such as antimicrobial peptides, phage therapy, and host-directed therapies hold promise for improving sepsis management beyond polymyxins?
Polymyxins is not going to go away. Let me make it very clear, because
Okay.
in one way or other way that sometimes when you are having as I'm mentioning, that E. coli, if you are coming in a urine, MDR, P3, PB3, PBP3, a site, then you are going to use the phosphomycin and the colistin and these polymyxin kind of the common, not the polymyxin B. Polymyxin, I am using the common terminology because polymyxin is the two, polymyxin B and polymyxin E. Polymyxin E is the colistin. Because polymyxin B is not excreted by the kidney, so hence it should not be used in urosepsis, in the urine infection, UTI. So colistin is the one alternative here to be used in place of the polymyxin B. So polymyxin is not going to go away irrespective of any other therapies coming in away and going. Nowadays, which we are encountering in couple of the patients, even we are the BioFire is saying the same thing. We are using the ceftazidime, avibactam and your STNM combination. Patient is not responding. Now we started thinking that it is the PBP3 E. coli is creating a problem. Then we go with the combination of the phosphomycin along with the colistin to treat the patient, because it's basically life of the patient is at the stake. You cannot take a chance. For an initial 48 hours, when you are giving the empirical therapy, you have to go full throttle, full dose, hard, and the maximum therapeutic doses. So this is how you are dealing with those subset of patients. You cannot take a chance. So as far as the other therapies are coming, they will work in there. You can use them in conjunction, but combination therapy is going to stay. Polymyxin not going to go away. And I think that polymyxin B is very promising. We are using it. I think it was being introduced way back in 2013 by one of the companies, and since then we are using it very successfully in good number of patients. Leave aside the IDSA 2023 guidelines, still it is being used in a different combination, different subset of the patient.
So regarding sepsis management beyond antibiotics, so how critical are non-antibiotic interventions like source control, immunomodulation, or fluid resuscitation in improving survival in sepsis caused by MDR pathogens?
Surviving Sepsis campaign is one of a forum which gives there its guideline, and based on that guideline we manage our sepsis. And since then, when it was first being come in 2001, the outcome of the sepsis patient started changing throughout the world. All those components which you have mentioned regarding the fluid therapy, regarding the source control, because sepsis management is a two-step management. Circulating bacteria you can kill by giving the antibiotic, but you need to manage the source. For example, for the chest, if you are having the infection, obviously your antibiotic is going to work. But for my source of the infection lying in my abdomen and which is having a surgical intervention, I need to address that because that's a source. Circulating your bacteria, I'm going to manage with the antibiotic. While we are doing the surgery, I'm going to contain that part. For example, perforation peritonitis, for my infected, perforated appendicitis, they are the source. Surgically has to be contained. So it's a two-step management of the sepsis. Antibiotic along with the source control. Regarding the fluid therapy is the main component of that surviving sepsis campaign, and the management of the sepsis one has to look into. Yes. And that's the one topic which I think is need a separate discussion.
Okay.
Yes.
So regarding the future of polymyxins in sepsis care, with the development of newer, more targeted therapies, do you foresee polymyxins maintaining a significant role in sepsis management, or will they be gradually replaced by safer alternatives?
I think I mentioned in my previous conversation right now, 5 minutes back, polymyxins are not going to go away. Polymyxins are going to stay. Polymyxins are the one thing which is going to be there, and in case of a different combination, where you are stuck with, even with you are having the biofire, even you are having your culture sensitivity, but your patient is not clinically improving. In that situation, you take a call and you start with your empirical, combinations to save the life of the patient. For example, your patient on the ventilator startings are going up, vasopressor demand is going up in the middle of the night, and your oxygen demand is going, patient's ABG is also deteriorating. What you will do that? My consultant in the middle of the night is definitely going to change antibiotic or escalating the antibiotic or changing a different combination based on the clinical situation and that particular epidemiology existing in my hospital. So antibiotic coming to your polymyxin part is not going to go away. It is going to stay here because we have not too many of the options available.
We had no other options.
We don't have too many of the options available. Hardly ever the antibiotics are coming. Companies are trying very hard to bring in new molecules. And my only concern is that the new molecules, before it is going to be established, the good new molecules, they should not be used left and right, and they have been just go down the drain by using just, can I say that not I'm not in a favor because just mentioning I'm a chairman to the infection control committee of my hospital for last more than 12 years. So my objective is to basically look into that somebody is not using misuse of the antibiotic, inappropriate use of the antibiotic. Empirically, you cannot go beyond 24 or 48 hours. Any antibiotic therapy in max, you need to write your notes. You have to place your explanation on that because it's everything CPR is online. So person sitting at the center in the clinical direct, they are looking at that these antibiotics were written to a particular patient at the max Patparganj, headed by the person, how it is basically response. So this is how we are working. And so the same thing I'm going to say that. So before you go with the new antibiotic, I think the company also has some kind of the responsibility other than the healthcare provider.
Yes.
The moral responsibility that the antibiotic should not be misused by using more, empirical therapy should not go beyond 48 hours in any case. It have to have a kind of the evidence, culture sensitivity report, or use the biofire or any other method to isolate and give the targeted therapy. That is the only way that we are going to save these thinned out line of the antibiotic, as well as we are also contributing for the antimicrobial stewardship.
Okay.
In that way.
Sir, some words of wisdom to our audience on antimicrobial stewardship practices, some best practices about antimicrobial stewardship and de-escalation practices, so that we can take away some of your good practices at Max Patparganj.
What we are basically, how we are practicing, I can share that how the MAX basically works. Almost now we are a group of 24 hospitals, small and the big throughout the country. And that how we are working for the antibiotic. No patient can have the empirical therapy beyond 48 hours, number one. Before you initiate antibiotic therapy, you have to send the culture and sensitivity. It starts from the casualty trials, goes up to the ICU. That's a rule, number one. Number two, that if you have that now the biofire we are using more frequently to get the information well within 1 to 2 hours, that makes our life much easier. So coming to the antimicrobial stewardship, antimicrobial stewardship is nothing. It is basically telling you that don't misuse and don't overuse. So when you use the antibiotic, only when you have the evidence, use the antibiotic only you know that this is a targeted therapy as a targeted therapy. But culture and sensitivity has its own limitation. Your yield is up maximum 50%. Because as a rule, your sample has to be mounted on the culture desk well within 30 minutes. Because as a rule, that dead bacteria never grows. And that does not mean your patient is not having an infection. So sometimes culture sensitivity and all that is not going to give you that kind of information. You use your clinical, depending on your epidemiology. Coming back to the point that how you are going to have a antimicrobial stewardship. Antimicrobial stewardship means infection control program. Antimicrobial stewardship is a part of the antibiotic therapy, and antibiotic therapy is a part of the infection control program. So antibiotic policy we have definitely how it is. Number one, prevention of the infection. Prevention of the infection can be done number by contact transmission by using your hand hygiene. Then coming to your environmental cleaning or surface cleaning. So you have to have a surface cleaning strictly in our hospital, and even in my unit. There is a surveillance. God knows that who is basically looking at you. If you are not doing your proper steps before touching and after touching, your name will be counted. Okay. And that name will be told, to the head of the department with respect with that your doctor or the nursing staff. This is how the system is working. Now coming to the environmental cleaning, objective is to decolonization. By doing the surface cleaning, all that you are decolonizing the bacteria, reducing the bacterial count, number one. Number two, coming to the colonization on the patient part. You are doing your, there is only a 4 indicator we use for the hospital acquired infection. That's a COTI, CLABSI, SSTI and WAP, right? So now to reduce the WAP, what do you do that? You basically do your WAP bundles. These all bundles are basically for the nursing staff to be executed, supervised by the infection control nurse and by the team leader of that ICU. How we are basically making it sure that they are following it or not, that every patient in each ICU, if the patient is coming positive for a hospital acquired infection, this is how we are working. We call the team leader of that respective ICU. Because 24/7 it is not the infection control team is sitting in the ICU and looking at that whether they are following the hand hygiene or not. Yes, we also have a kind of the habit that we also keep a watch on that, because if somebody doing the hand hygiene or not, cleaning part, we have a 8-hourly cleaning of the floor and all the railings and all the, with the, that chemical passed by the central infection control committee team. This is how the 24 group of the hospital work, because there is a central team which decides everything, taking the help of the local team. Now coming to the decolonization part, it's very simple that how you are doing in a day to day. You brush, you take a bath. Why? Because you are doing the decolonization of your oral cavity. You are taking it because every time you are carrying a bacterial load of 1 milligram per kilogram body weight. So same philosophy applies to the patient, because patient cannot do it of its own. So you have to give them a body bath, body cleaning, oral cleaning, and all those practices. So antimicrobial stewardship is nothing else. First is the preventive part. Second is that, which I mentioned, that empirical antibiotic cannot go beyond 48 hours. Before you initiate an antimicrobial therapy, you have to send the culture and sensitivity. This is how we are doing it. And sometimes when you initiate the antibiotic therapy, after 3 days you found that after 48 hours, and these values are being picked up. How the system is working? For example, we take the culture controls, we have sent a screening culture. Screening culture means you have sending the ET, oral. If patient is not intubated, then or the oral swab, then paired blood and the urine. These samples are, as a sacrosanct, will send for all the patients. Okay. Now, if patient is referred from some other nursing home which is intubated, having a central line, arterial line, a dialysis catheter and the Foley's, then we send all the culture of all this site, labeled, will be sent. If the intubation is intubated rather within 24 hours coming to the site, if it is negative, we'll continue with the same tube. Central line within 24 hours, negative, we'll continue with the same. We are not going to remove, but anything beyond 48 hours, the line will be changed in the casualty itself, casualty trials, pending the culture. Culture they will take. So we know that patient who is coming to the ICU, they are already having a colonization or not for the MDR. If they are having the colonization for the MDR, they will be cohorted in isolation room and kept on the side of the ICU, managed by 1:1 ratio of the nursing. So antimicrobial stewardship, this is how we are practicing. Every day, a clinical directorate is the max is having a 2 vertical, clinical and non-clinical. The clinical vertical head is your CEO, the non-clinical person, and the clinical side head is your clinical director. Dr. Sandeep Buddhiraj is the PEN group clinical director. So he is the one who is responsible for every kind of the clinical related issues, be it your all 13 committees, including infection control. Under his command, there is a one team is sitting. I'm sorry, I'm having a viral for last 4 or 5 days. No problem. So under his command, there is a one team is sitting, which is capturing your data of the antibiotic uses for every ICU, every ward. It's known as DDT. We share it on a monthly basis or a day-to-day basis. And second part, the most important part is since 2013, we are having a software, Pentaho. A culture is basically captured from my ICU. Microbiologist, because they found that, okay, this bed number 3, A-wing, a patient is having a ET culture positive, and they uploaded the report because everything is on online CPRS, so they capture the data there. This Pentaho will capture the data. Okay, 60 cases of a suspected WAP, 30 cases of the COTI, voila. On a real-time basis, the nursing staff will come along with the team, and they are going to discuss with me, should it be colonized or it should be treated. So as a rule, if it is a infection or a colonization, you have to change the device, endotracheal tube, Foley's or a central line. Accordingly, this is how we are working. And this is sacrosanct, we are doing it on a religious basis. Antibiotic use, as I said, there is a rule strict. No antibiotic can go beyond 48 hours empirically. And if you wish to continue or changing the antibiotic in the middle of the night, you need to place your notes that why you want to change it.
So does the software help in de-escalation also?
Yes, it is basically helps in de-escalation because we keep a watch as a head of department, not here but all the issues. Because in a team, on a HICC meeting, the all head of the different ICUs sit together, the concerned people from the critical care area, and where this is being discussed. It's a part of the antibiotic policy at the max. This is how we are working. Maybe this thing is going to help the people in the different other. But remember one thing, being a healthcare provider, you have the moral and ethical responsibility to avoid the misuse of the antibiotic. It is not that someone else will come and tell you, no, it's you. And remember, it is the bacteria who get resistant, not the human being. And no one is basically immune to that.
Sir, sometimes our culture comes negative,
Okay.
but our patient is not clinically better. So in that
I
case,
tell you that you cannot solely depend on the culture sensitivity report.
yeah,
A blood culture or for any culture, as I said, the maximum yield is 50%.
yeah,
And that too depends on when you have mounted your sample within 30 minutes of the culture media. So there is a certain confounders which is playing their role for the yield of your culture sensitivity. So that is the reason. For any guideline, what they mention, the guideline has the two component. One, your quality of evidence, and second is strength of recommendation. Now, quality of evidence will come with the research you are available. Based on that, you will draw your grading system, grade 1, grade 2, grade 3. And now the recommendation depends on, for example, the X number of people are sitting here. I'll say if the 90% people will say, okay, I'm doing this thing, it's a strong recommendation. If up to the 75% people will say, I'll say the moderate recommendation, and less than 25, I'll say it's not. So this is how the guidelines are being made. But over and above, there is a one column are also being kept, the best clinical practice. For example, there is a particular point, evidence is not available, but the people who are sitting in the guideline or member of the guideline committee, they say, okay, I'm doing and I'm getting this result. So that's the best clinical practice. So on that basis, your clinical assessment of the patient at that particular time is going to decide about the antibiotic therapy. You have to put down your notes, why I have changed. And this is we are practicing. Anytime when the antibiotic is being changed, we already ask and we look at that notes why you have changed this antibiotic. So you maybe at that moment of time you are the best person to judge about that my patient had an increase in the vasopressor, increase in the oxygen demand, patient is acidosis, ABG is deteriorating, so I change the antibiotic based on that. So based on that you take a call on clinical basis. So clinical criteria will always be a part of your all the guidelines. It's the same for the IDSA. They says that these are not a sacrosanct. We are guiding you that you use a particular combination, but also depends on your clinical situation. You take your call of the different combination. This is how the basically people work, and this is how we are working that way.
So, sir, but my one more query which has risen in my mind is regarding you said about all the best practices which is happening at one of the top-notch institute, Max. But what about the ICUs where these facilities are not available? Biofire sometimes is not easily available, and these softwares, fancy softwares, are not available at these centers. So what about that? How would antimicrobial stewardship basic practices? What would you suggest to our audience so that they do not miss out on like 48 hours antimicrobial antibiotic de-escalation is there, hand hygiene is there, and what else they can
What we
practice?
found that by practicing your hand hygiene, by practicing your infection control practice in your respective ICU, means you are having a proper cleaning, proper isolation of the patient. Isolation does not mean that you need a negative pressure room. You can cohort the patient in the one corner of the ICU if your patient is having a hospital acquired infection. But remember one thing, there is no escape for any ICU, whether there's a level 1, level 2, level 3 or working at tier 2, tier 3 and all. You cannot escape that I cannot send the culture and sensitivity. Empirical therapy has to be dissuaded at any level, irrespective, because that is the one reason which is adding into the antimicrobial resistance. It is only you cannot enforce that by the law. Government of India is also doing its job. They have come out with their their guidelines regarding antibiotic resistance, how you have to use, how you should not use. But at the periphery, I am saying that the periphery, you are dealing more with the community acquired infection, and community acquired infections are not that virulent. So your antibiotic should not go with the level 2, your BLBLI combination with the carbapenem. It has to go with the basic antibiotic. Because maybe, and 50% of the time you are dealing with a viral infection, not with the bacterial infection. So ending up giving the antibiotic for each and every patient is the reason what we are facing, the music we are facing right now. So I think this message has to go crisp and clear that empirical therapy should be dissuaded. If you have to give for the initial 48 hour, have to have those basic investigation, your complete blood count and all those gives you a fair idea you are dealing with the bacteria or the viral. So what during our teaching to the students, we also discuss the same thing. Okay, looking at these, investigation basic, how you will decide that it's a viral infection or the bacterial infection. And you know that based on that. If your counts are not going up, your neutrophil counts are not going that high, you are dealing with the viral infection, then why you have to end up giving antibiotic? Okay, I'll give the antibiotic because my patient is having a central line, endotracheal tube and the catheter. Okay, then give it as lower. You start with the basic of the penicillin group or maybe the basic of the first generation, second generation of the cephalosporins. Why to go with the BL-BLI combination? Antibiotic is basically for all of us. It's not for that subset of the patient. Maybe the one day my own relative, my near and dear going to come to the same bed or any other ICU. They are going to have the same problem. It is the bacteria which get the resistance. It is not the human being. This is the myth that if I'll take the too much of the antibiotic, I get resistant. No, you are not get resistant. You will remain the same. It is only the bacteria is going to get resistant, which is going to create a problem. So my take is that infection control practices are the one way of moving into that direction of the antimicrobial stewardship and containing your antibiotic resistance. Second part is that we have to be judicious of using the antibiotic and deciding whether it's I should give antibiotic, I should not give the antibiotic. That is the one question need to ask, and that's a very simple. Looking only at the CBC, looking at the basic count, you know that it's a viral. I'm not going to treat it that way. If your patient is not having a fever, if your patient is not hemodynamically unstable, then why to go with that much of the high group of the antibiotic? No, absolutely not. Yes, you can have some kind of preventive and dissuade using the fluoroquinolones as a rule. WHO itself says that if you are having any other option available for the same bacteria other than the fluoroquinolones, go with the fluoroquinolones, go with that group of antibiotic, dissuade using the fluoroquinolones because that's notoriously known to cause the antimicrobial resistance.
Got it.
Number two, duration of the therapy. Most of the infection, even with the MDR, you cannot go beyond 10 days. 7 to 10 days is good enough. Some tests now much cheaper. You can use the procalcitonin test to de-escalate and to decide about your duration of the therapy. That gives a fair idea. Easily available, not that costly.
Correct.
Previously as it was. So these are some of the tips which we can follow other than the infection control practices. In those setup which is having a less of the support system, less of the resources, there you can also do the antimicrobial stewardship in your own way and contributing for the containment of the antibiotic resistance.
Correct. Fine. So any questions from the audience?
So how is nutrition as per the management subject?
Nutrition, remember one thing, what I consider and I teach my students that there is a 3 component of the management of the critically ill patients. One is your treatment part, second is your physiotherapy, third is your nutrition. So nutrition is the first and foremost. If a patient is nutritionally deficient, your everything will go haywire. Irrespective you made an exact diagnosis, you are giving the exact treatment, your patient is not going to behave the same way. So nutrition is the first and foremost part one has to look into. And to decide about the nutritional therapy, you need to take the history of the patient. For example, the patient started from the periphery. By the time it reached to your ICU, it is already 2 weeks late. So guideline will not apply here. That says that you cannot start the your nutrition therapy, give it a 3 to 5 days chance. No. Take the history. When did your patient last had a normal meal? Sir, it was, sir, 1 महीना हो गया. What is that? खाते हैं भी, हाँ सर खाते हैं, पर कितना खाते हैं? सर 1 चम्मच 2 चम्मच. So it means your patient now is nutritionally deficient since 1 month. Take that consideration. So start your nutrition immediately, as early as possible, when your patient is hemodynamically stable. In that patient who is in a shock, no need of giving any nutrition until your vasopressor demand has come down to the minimal dose. You can initiate your.
Do you want to use kitchen feeds or the?
It totally depends on the mode. It depends. So your patient can eat, give them oral, best route. If patient cannot eat, go with the enteral, and third is your total parenteral nutrition. Then this is the sequence. And remember one thing: whatever calorie you have calculated for that particular of the patient, never give it from the day 1. 0 to 3, 3 to 5, and more than 5. 0 to 3, whatever calorie and protein you have calculated, you achieve maximum 50% of that. From 3 to 5 days, you go up to the 80%, and beyond 5 days, achieve 100%. Clear? If you give it from the day one, it will cause a refeeding syndrome. And when you are initiating your nutrition in critically ill patients, always send the control value of the electrolytes, phosphate, potassium, and the magnesium. That will give you an idea whether your patient is going to land into a refeeding syndrome or not. Right? Anything else? MCR1 means mobile cholesterol resistance gene. So MCR1 gene, if it is present, it means your polymyxin group of antibiotic is not working. Then you have to use the different combination, the dual carbapenem therapy along with your phosphomycin. Then those come. But God forbid, we do have a 4 or 5 patients in a 1 or 2 month, which is a pan drug resistance. And definitely we have a very tough time to save the life of these patients, even using the different combinations. Sometimes we are lucky, and most of the time we are not lucky to manage these patients. So MCR1 gene is basically means mobile cholesterol resistance gene. Cholesterol means the cholesterol group of the antibiotics are not going to work. And the culture report, which as you said, in biotech, they will give you always the intermediate for the cholesterol. And that's the reason that polymyxin group of the antibiotic should always be used in a combination, not as a monotherapy. So now coming to your pan drug resistance or MCR1 gene, you use the different combination and different combination. If I am saying that dual carbapenem therapy along with the phosphomycin, dual carbapenem therapy with the other. So you have to make your own combination. Still there is no fixed and hard line, and still not a fixed and hard line to apply the same guideline. You are going to save the life of the patient. It totally that way. But being an intense, we put in our wholehearted effort. The entire team put in a wholehearted effort to save the life of that patient. This is how, and this is basically a dilemma, and this is going to increase until we will be honest enough to help with our own moral and ethical values to help in reducing the antimicrobial resistance by avoiding the misuse of the antibiotic. That's the definition of the antimicrobial stewardship.
Patient is very sick and terminally, and again very high resistance of antibiotics is coming. Thinking in terms of end of life care, stopping all antibiotics for that patient despite knowing that he is resistant, and isolating him to a other place so that the bacteria doesn't go to other people. Will it be a wise decision to go for that?
End of life, remember one thing, whenever you are taking a route on a daily basis, always decide about the futility of treatment. If you found that patient has reached to a point of no return, then that patient fulfills the criteria of the end of life. Means you need to discuss with the primary consultant, and all the treating teams are on the same line. Then you have to sit with the family members and tell them that your patient, the medicine is not going to help you. Then you have to give them an option, because these patients now should not be given a definite therapy or aggressive therapy. You know that multiple organ system involved, and this patient is not going to make it, and you are continuing with that. It's basically inhuman that way. So why a patient has to die in isolation and ICU? These patients need to be kept in a separate way, providing the home separate nursing into the room along with the family members. So end of life is definitely when you found the futility of the treatment, the patient reaches to a point of no return. And by definition of the critical care should not be provided to those subset of patients who are suffering from the terminal stage of illness and reach to a point of no return, means end of life. That's the definition of your very branch, very specialty. So following those rules, these patients need to be given, family to be discussed, all stakeholders has to sit together. This is how we practice, and this is how we do in our ICU on day-to-day basis. So futility of the treatment has to be decided on a daily basis. And once you draw that line, discuss with all concerned doctors. If everyone on the same line, discuss with the family member and decide and tell them very clearly. Now you are having two ways. Either you would like to stay in a hospital, you would like to take patient back to your home along with the family, or you with the home care. So at least the patient is not dying in isolation. You are doing a great service to that humanity and that man, because at the time of the crisis, everyone needs their near and dear together. What in ICU we are doing, we are separating them. We are not allowing the family members to at the time, the last time. So this is called a humanization of the ICU. When you are taking these things into the consideration, you are becoming more empathy and the compassion, bringing into the patient care. So end of life is the one part. It will not apply only to the malignancy patient. It applies to any specialty, any pathology where you found that my patient has reached to a point of no return. Involve the family, involve the all stakeholders, and take the call. Whatever you said, it's a right decision. Isolate these patients, keep them with the family members, provide the facility there. If they wish to stay in a hospital or they wish to take the patient back to the home along with the facility, following the law of the land. You stop everything, nothing. When the patient is dying, fill the last wish of the patient and the family. That's all.
So, any more questions from the audience? So, in that case, sir, I would like to close the session. Thank you very much, sir.
Thank you.
And thank you to the audience for your kind attention.